Continuing on with the brainstem, we've got the next part of the brainstem that we've got is the pons. We'll be having a look at its external features, internal features, and blood supply. In terms of the external features, we have firstly the ventral surface. The ventral surface is largely featureless. It has a midline groove and two convexities either side of it. The convexities merge laterally with the front of the middle cerebellar peduncle. Turning our attention now to the dorsal surface. The dorsal surface forms part of the floor of the fourth ventricle. The floor of the fourth ventricle is known as the rhomboid fossa. The major feature is that you've got a midline groove and you've got two eminences either side of the groove, and these eminences are known as the median eminence. The major feature within the median eminence is these two round-like masses called the facial colliculi. The significance of the facial colliculi will be seen once we have a look at the internal structure of the brainstem. The final thing is attached cranial nerves. Now, attached cranial nerves, firstly we've got cranial nerve 5, which attaches to the anterolateral surface about midway on the pons. And the major thing to note here is that there is a major sensory root and there is a smaller motor root which arises above it. From the pontomedullary junction there are a number of nerves from medial to lateral. The most medial of these, emerging between the pons and the medullary pyramids, is the abducens nerve or cranial nerve 6. Lateral to this we've got the main trunk of cranial nerve 7, and then we've got the nervus intermedius, which is the parasympathetic and sensory fibers which are carried by cranial nerve 7. Lateral to the nervus intermedius, we've got cranial nerve 8. Now, cranial nerve 7 and 8 are commonly affected by cerebellopontine angle tumours, the tumours in this region here. So those two nerves are typically affected in that case. The most common cause of cerebellopontine angle tumours is actually acoustic neuromas, which is the subject of study for many neuro courses around the country. And basically what it is it's a tumour which arises from the vestibular component. It's a bit of a misnomer, vestibular component of the cranial nerve 8. Alright, moving on now to the internal features. The internal features of the upper and lower pons are quite different, so we'll have a look at a section of each of these parts. So, starting off, we'll talk about each of these components of the brainstem, which we've got listed on the left here. So firstly, we've got the tectum. Now the tectum, as you remember, is a part of the brainstem which lies behind the ventricular system. So in this case, it's formed by the medullary velum, which lies in front of the cerebellum. The tegmentum is a part which lies immediately in front of the ventricular system. The tegmentum consists of nuclei, ascending tracts, and interconnecting tracts, and the rest of it is filled with reticular formation. In the upper part of the pons, there's only two cranial nerve nuclei, and these are the motor nucleus of the trigeminal nerve, which lies medial to the chief sensory nucleus of the trigeminal nerve. The ascending tracts are formed by the medial lemniscus, which lies medial to the spinothalamic tract. The interconnecting tracts in this part of the pons, there's only one set of interconnecting tracts throughout the whole brainstem, and that is the MLF, or the medial longitudinal fasciculus. And this once again controls the coordination of eye movements between cranial nerve 6 and 3 and 4 above. The ventral to the tegmentum, the rest of the space is filled in by reticular formation. Ventral to the tegmentum, we have the part derived from the cortical fibers, and this includes descending tracts. This includes descending tracts and also pontine nuclei. So pontine nuclei split up the descending tracts into a number of bundles. And there we go there. Moving on now. This is a section of the lower pons, and once again we'll use the same type of framework. So you've got the tectum, which is the medullary velum, which lies behind the ventricular system, as you remember, and then we've got the tegmentum, which lies in front of the ventricular system. So it's this part of the brainstem here. Within the tegmentum, the things that we're going to see are nuclei, and ascending and interconnecting tracks. One of the nuclei has already been, one of the sets of nuclei has already been labelled, and this is the reticular formation, which fills the space in between the other cranial nerve and special nuclei. With the cranial nerve nuclei in the somatic motor column, so if you remember the order of columns from medial to lateral, we've got the somatic motor, then the branchial motor, then the visceral motor, then we have the visceral sensory, special somatic sensory, and general somatic sensory, in that order from medial to lateral. The first column that is present in the lower pons is the somatic efferent nuclei, and the nucleus here is the abducens nucleus. The abducens nucleus has the fibers of cranial nerve 7 which are wound firmly around it, and this arrangement of cranial nerve 7 fibers winding around the abducens nucleus produces the facial colliculus, which we talked about in the floor of the fourth ventricle. The next cranial nerve nucleus is the branchial motor column, and this corresponds to cranial nerve 7, the facial motor nucleus. The next column over, the visceral motor nucleus, does not exist in the lower pons. That's more in the medulla, so we'll leave that for now. And that same goes for the visceral afferent column. There's not much in the medulla. So the next column over to have a look at is the special somatic column, special somatic afferent column, and that consists of the vestibular nuclei which lie in the lateral part of the floor of the fourth ventricle. Lying slightly lateral and anterior to the special somatic column, we've got the general somatic column, and this is formed by the spinal trigeminal nucleus of cranial nerve. Is the spinal trigeminal nucleus. The next thing that we have, the next nucleus that we have, is a special nucleus. It's not a cranial nerve nucleus, and is known as the trapezoid body. There. So the next thing, apart from the nuclei, the tegmentum also consists of ascending and connecting tracts. Now, the ascending tracts include the medial lemniscus, which lies immediately adjacent to the midline, but it's horizontal in this position here. And lateral to that, we've got the spinothalamic fibers. The connecting tracts consist of the medial longitudinal fasciculus at the back of the tegmentum, either side of the midline. The lower pons also consists of a ventral part which lies in front of the tegmentum, and this consists and the ventral part is made up of descending corticospinal fibers as well as the pontine nuclei, as we talked about before. The final thing that we'll need to do is consider the blood supply of the pons. And the important thing for the blood supply is that there are medial and lateral zones. So there is a midline zone, which is between these two lines, and a lateral zone, which lies lateral to that this line here. So it's this area here. The midline zone is supplied by pontine branches of the basilar artery. The lateral zone is supplied by the, I believe, the superior cerebellar artery, as well as the anterior inferior cerebellar artery, so the ACA. Now, you may ask, what's the point of remembering these arteries and these zones? And the point is, you often have vascular syndromes in the midbrain. You have vascular syndromes in the brainstem. And you can explain the symptoms of these if you understand what lies in the midline zone and what lies in the lateral zone. In the area of the midline zone, the structures you have include cranial nerve nuclei 6, a bit of the trapezoid body, which doesn't produce major symptoms, and you've got the medial lemniscus as well as the MLF, and also importantly you have the pontine nuclei. So once again, just highlighting these structures. So you've got that, you've got the trapezoid body, you've got the ML, and then you've got the descending tracts. So you've got the MLF, and then you've got the descending tracts. Now, if all these structures get affected, you basically produce a contralateral hemiplegia because the descending tracts have not yet crossed over to supply the opposite side of the spinal cord. You produce a contralateral hemianesthesia, but not loss of pain sensation because you knock out the medial lemniscus, and you also lose, you also paralyze the ipsilateral, or the same-sided, abducens nerve. And if you damage, so that leads to ipsilateral lateral rectus problems, and what that means is basically you can't look towards the side of the lesion. If the medial longitudinal fasciculus is also damaged, you also get the problem that both eyes cannot look towards the direction of the lesion, and that's because cranial nerve 6 sends fibers via the medial longitudinal fasciculus, which coordinates eye movements with cranial nerve 3 to allow that conjugate eye movement. So often, so that's what happens in terms of symptoms. Often in diabetes, you can also get the medial longitudinal fasciculus getting affected by itself, in which case, no, I'm not exactly sure if it's diabetes, but in a number of conditions you've got the medial longitudinal fasciculus being affected by itself. And what happens here is coordination between cranial nerve 6 and cranial nerve 3 on the opposite side is lost, and you get the syndrome of intranuclear ophthalmoplegia, which basically means that when you look towards the side of the lesion, basically what happens is cranial nerve 6 can work on the side of the lesion still, and your eye moves towards that side, but the opposite eye can't move, so you get a disparity in your visual input, and this leads to nystagmus of the abducting eye, and that's what intranuclear ophthalmoplegia is, so in case you're interested in that. Anyway, got a bit sidetracked there. The if we have a look at the lateral zone now, the lateral zone, if there's a vascular syndrome here, you get cranial nerves 7, you get cranial nerve 8 and cranial nerve 5 being affected, and you also have the spinothalamic tract being affected. Now, the effect of the lesion of the cranial nerve 7 nucleus is a ipsilateral paralysis of the all the facial muscles. It's essentially a lower motor neuron lesion of the face, and the next thing, a lesion of cranial nerve 8 will lead to a disparity in. It will lead to problems in mainly vestibular maintaining equilibrium or balance, and a lesion in cranial nerve 5 nucleus in this area is basically a lesion to the spinal trigeminal nucleus, so you lose pain sensation for the ipsilateral face. Injuring the spinothalamic tract will cause a contralateral loss of pain temperature sensation. So because the spinothalamic tract has already crossed at the level of the spinal cord. And that's basically it for the PONS.